what survival metrics do you use and share with your patients for both AL and TTR?
Well, let me start with TTR. So, there's two staging systems out there for ATTR cardiomyopathy. One is the Mayo stage publication by Martha Grogan at the Mayo Clinic, where they looked at patients with wild type. They'd saved blood on these patients and retrospectively looked at two biomarkers, NT-proBNP and troponin T, and looked at the subsequent survival in these patients. And they came up with 3 stages. So stage 1 was if you had an NT-proBNP less than 3,000, and you had a troponin T less than 0.05 nanograms per milliliter, that would make you stage 1. If you had both of them above that, so an NT-pro greater than 3,000 and a troponin T greater than greater than 0.05 nanograms per milliliter, that was stage 3. And then anything one or the other was stage 2. So the stage 3 patients had the worst prognosis, under 2 years. And the patients who were stage 1, who were below both those biomarkers, they had the best prognosis, close to 6 years, 5.5 to 6 years. And then you have the patients in between, which were about 3.5 years. That's the stage 2 patients. So in addition to the patient's echocardiogram and how much diuretics they're on and your other gestalt type of markers of how someone's going to do, using that staging system is another way we will speak to patients. The other staging system that's used in ATTR cardiomyopathy is the Gilmore staging system. Julian Gilmore at the National Amyloid Center in London actually, again, looked at a large cohort of patients, and instead of looking at NT-proBNP and troponin, looked at NT-proBNP and estimated GFR, in this case less than 45 mLs per minute per meter squared. And the same thing, if you had an NT-proBNP that was less than 3,000 and a GFR that was greater than 45, you were in stage 1. If you had an NT-pro greater than 3,000 and a GFR less than 45, you were in the worst stage, stage 3. And pretty much the survivals were pretty much parallel, more or less, what the Mayo staging found. So those are the 2 staging systems that I will use in ATTR cardiomyopathy patients to enhance the discussion that I'm having with a patient. Now, remember, these staging systems were derived without treatment. So right now, if I'm going to put somebody on tafamidis or another medication with those numbers, I can't really give them the accurate numbers because you would assume that survival is going to be better. But that's the best we have. As far as AL amyloidosis, there is a Mayo staging system 1, 2, 3, and 4, which was revised from 2004, the 2012 revised staging system. And again, they look at 3 variables. They look at the NT-proBNP, a troponin T, in some cases an I, and then the difference in the involved and uninvolved free light chains. So in this case, stage 4, which is the worst, would be an NT-pro greater than 1,800, a troponin T greater than 0.03, and a difference in the involved free light chains and uninvolved of 180 milligrams per deciliter or per liter, or what would be 18 milligrams per deciliter. And so again, the concept being that patients with stage 4 have a very poor survival, 6-month mortality of 50%, whereas patients in stage 1 will have a much better prognosis. And obviously the ones in between. But again, this is derived before daratumumab, before some of the better chemotherapy agents we have. And I know Dr. Witteles hopefully will talk to us about his most recent publication about looking at the survival in these patients in the newer area of having, daratumumab and other medications.